colleagues,
Yeah.
because postgraduate surgery is okay.
Good morning. Today we will have a session on imaging. It should be on MRI in rectal cancers and perianal fistula. We have a very avid teacher, our very close and dear Dr. Shubhro, who is the intervention radiologist at Narayan group of hospitals, and he does most of the interventional work in Calcutta. So, Dr. Chowdhury, it's yours for next 1 hour.
Thank you very much, Mapanda, and it's a real pleasure because I know that in West Bengal has always been a very good place for medical education, and traditionally it has been a great place to learn medicine, and it's actually a pleasure and a privilege to be part of that program. So I'm going to talk today a little bit about pelvic MR, concentrating on coloproctology. I don't know how much I'll be able to cover because, to be honest with you, the subject is very vast. And, if we start talking about rectal cancer, there are so many aspects of rectal cancer itself that one can cover. I'll try to keep myself clinical as much as I can without going into very great technical details of, of scan protocols and stuff like that. Keep myself to clinical. So what I'm going to talk maybe over the next half an hour first is on rectal cancer, and that is based on our experience. And we were very, very lucky to work with a team of 12 colorectal surgeons. And this work is mainly work from England, although that has continued in India, and I do the same sort of practice here in Calcutta as well. And that is based on few things, and it started way back in 2004. And immediately after the 2003 paper of Gina Brown, which proved that MR for rectal cancer is the best staging modality that we could get. And then we got into it, and we also published a number of things, of which this one, I think, was the most important paper that we published or presented, was rectal cancer on thin section imaging, MR. And we studied the pitfalls based on the pathology specimen and also doing an MRI of the pathological specimen, the surgical specimen. So we actually understood the pre-surgical MRI, the pathological specimen, the limitations of the pathological specimen, the limitations of MRI, because we had all three side by side, slice for slice. And that was, I think, the biggest learning example. And for that, you see the names of my radiology and my pathology colleagues, most important, wonderful pathological colleagues. So we used to... So, and then, of course, and then a second piece of work, which was on lymph nodes and the difficulties of accurately characterizing lymph nodes on MRI in the setting of a high histological node yield. And this is something I would explain again as I go along, that what is the issue about people saying your nodal accuracy is good or bad. So things I will just mention is endoanal ultrasound, which is something that is important, but it is mainly limited to T1 and T2 rectal cancer. And endoanal ultrasound versus MRI. MRI is gradually winning the battle. Even in T1 and T2 MRI, in the last 3 years, there are papers that have come out regarding that. I'm not going to talk about T1 and T2, which is very, very important in the setting of transanal mucosal resection, of course, but which Birmingham was a big center for. And, I think, what was the name of the trial? There was a Scott trial or something, but there was a big trial that was centered on Birmingham, which proved the role of TEMS in early rectal cancer. But in a country like ours, which is a non-screening country, such early rectal cancers, T1 mainly and some T2 rectal cancers, are very rare. So I'm not going to talk about endoanal ultrasound, but having said that, endoanal ultrasound is something that is great. I do it, and it is a great technique because you can see the Big Mac. We call it the Big Mac because the 5 layers of the bowel wall are clearly visible. Let me just move this here. on endoanal ultrasound, you can see the 5 layers of the bowel wall, and to differentiate between the depth of submucosal invasion, just the depth, SM1, 2, 3, Hackett levels, all of these things is not possible on MRI. It is possible with endoanal ultrasound. Okay. The thing I will also not mention is CT, because a CT in our country, in a lot of places, is used as a staging modality, I know. And CT is actually very, very good. Only recently, I reviewed a paper for European Radiology only 3 months ago. I think it came from India. You're not told which country the paper is from. Unfortunately, got rejected because of some limitation. But in it, it showed very clearly, and we have shown it as well, that actually, if you want, you can see the mesorectal fascia on CT. You just need to look at the CT with the eyes of the MRI. You need to reformat the CT perpendicular to the long axis of the rectum, like we would do in an MRI. But you can, if you want, you can see CRM invasion. You cannot see the bowel walls. You cannot see vascular invasion. You cannot see you cannot characterize lymph nodes. So MR is superior. But it is not that CT is an absolute useless technique, particularly because it is one common technique by which you can combine distance staging and local staging at the same time. Nowadays, in our institution, we have a dual energy CT scan in which we can do all sorts of iodine mapping to identify the tumor more accurately. Again, I'm not going to talk about this today, but I just want to give it in your head that don't poo-poo CT completely. It is a good technique if you are wanting to look at it. It should not be read by somebody who only does CT. It should be read by somebody who does an MRI, so that you can look at it with the eyes of an MRI. Of course, lung, metastasis imaging is with CT. I know there is a great tendency in our country to do PET at the drop of a hat. But to be honest with you, PET CT is not a routine imaging investigation in the investigation of rectal cancer. I must mention it very clearly. PET CT is not a routine investigation. I know that we think that, okay, we are getting two birds with we are hitting 2 birds with the same stone. We are getting a CT scan, oftentimes a multiphasic CT scan. But you have to remember one thing, that bowel cancer is almost always an adenocarcinoma. Adenocarcinoma has a false negative rate on PET CT of up to 20 to 25%. They are often non-avid. And the fact that all the subtle characteristics of CT and MR are not decipherable on a PET CT done primarily for the PET. If you are doing it primarily as a CT scan and then adding the PET, then that is okay. But when I mean that I do a CT scan to assess rectal cancer staging, I do a thin section, I do perpendicular to the long axis, I do MPRs, and I do all sorts of things. So a routine PET CT is not a replacement for an MRI or even a whole body staging CT. So the Big Mac, we talked about this, the bowel wall, we have already talked about this, the 5 layers of the bowel wall with high resolution Hitachi scopes. You can actually see this very, very well. So what is the main role of MRI? I think some of you, this is my most commonly used slide, and I might have used it in other places. So apologies if you have seen it before. But the main role of MRI is to identify rectal tumors with a compromised resection margin. And this compromised resection margin at the circumferential resection margin at the CRM, at the mesorectal fascia envelope, can be due to T, which is a tumor, can be due to the node, a node, or it can be due to extramural vascular invasion. It can be due to either of these three. It is very important to understand this. It is not just T. And this MR is accurate in up to 94%. And the second sort of role of MR is to triage between surgery or the correct neoadjuvant treatment. And the correct neoadjuvant treatment has changed from the days of writing this slide. Not only can you offer short course radiation, which we will talk about, long course radiation or long course chemoradiotherapy, LCRT. or what is nowadays called total neoadjuvant chemoradiotherapy. Okay, so these are the three main neoadjuvant treatments, right? And of course, that decision is taken in an MDT. That decision is on a patient-to-patient basis. I am nobody to come here and lecture you just to say that this is what should be done, because that is not the right way to do. Now, this is the rectal specimen, right? This is a total mesorectal excision specimen. As you can see, it is an exceptionally good grade 3. Yes, grade 3 is good, 1 is bad, right? So it's a grade 3 specimen, shining, glistening mesorectal envelope. And this is the slice, that the MRI of where the tumor would have been, somewhere in the middle of this. Okay, and here is the tumor. Here is the breach, you can see. Here is the mesorectal fascia. You can see that very, very well, that black line around the rectum. Here is a breach, and this breach is longitudinal, and you would see it going along a vessel. So this is actually a mural vascular invasion. This is not a tumor breach. This is a mural vascular invasion. These are things that we realize later. This possibly is a tumor vascular invasion. This possibly is a vascular invasion. But here is basically the tumor. And if you look at the specimen, here is the specimen. So this is the CRM. Can you see the tumor corresponding to this? And can you see this vascular invasion? Hey, Makunda, you can see my arrow, right?
Yes, 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 we can see.
Yeah. And here is the vascular invasion on MRI, and here is it on the specimen. Can you see how accurately MRI predicts what is there on the pathological specimen? So just to reinforce this to you, and just to say to you that the holy grail of radiology has always been to mimic pathology, has been meant to mimic histology. I think nowhere in the body do we come closer to this holy grail than in rectal cancer. And here is the specimen again, and this is another part of the tumor. And here is the tumor again a similar broad T3 breach. You can see that this has been labeled as vascular invasion by the pathologist. This is my pathologist labeling this slide, right? Now, can you see this one? And this is where I come to where the difficulties of reporting a rectal cancer is. See, I would report this broad-based bulge into the mesorectum as a tumor bulge, tumor breach, right? This I would report as a vascular invasion, because you can see it is going along the line of a vessel, and here it has projected and burst out of the vessel. And this is called extramural because it has burst out of the vessel, right? So this one I would have reported as T3, but as it happens, you can see that the pathologist thinks that this actually is also part of a vascular invasion. So practically it doesn't matter, because both of them contain tumor, and both of them are approaching the CRM. But the point is that the staging will become different, right? Because I would call this T2, I would call this T3 in whatever, whereas the pathologist would call this T2, but EMV2, EMV3. So the staging will become different. So whether what we call the number that we call is less important than accurate prediction of the tumor spread, because it is the tumor spread that is going to make you call whether you're going to take the patient straight to surgery or you're going to give the patient some neoadjuvant treatment, and what sort of neoadjuvant treatment you're going to give. So here is the, apart from Dr. Shah, if the others could please mute their mics. That would be great.
Milind, the other people mute.
Yes, sir. I'll just.
There's some disturbance.
So is that something that you understand the specimen? And I would just like to superimpose the histological specimen. Okay, this is the histology slide of the same patient. And as you can see, why would a pathologist call this? See, this is tumor. You can see the purple, the tumor. And here is a vessel, and that is why he says that this is part of a vessel where the tumor has breached. And here is also a breach, and this I would have thought is tumor, but the pathologist thinks that it is also a vessel. Okay. Now, I do, of course, would not be able to call that. And look at the MRI, and this is the slice, and look at how accurately the MRI predicts that histology, that particular slice that we saw. Okay. So this is what I want to show you. I want you to settle on this picture, that this is how good MRI can be. And, we showed that. Anyway, so with that little background, I'm just going to delve into more of the meat of the talk now. So the 4 stages of rectal cancer, I'm not going to tell you this because you know this. T1, T2, T3, and T4. Just remember, T3 is divided into T3 A, B, C, and D, depending upon how far the tumor has progressed. And I'll show you examples in a second. And T4 is where it either laterally goes into the pelvic sidewall, in the front goes into the bladder, or the uterus, in the back goes up to the presacral fascia, or in the upper third of rectum, and this is very important, what looks like a T3 tumor. If the anterior peritoneum is involved, then it is also a T4A. Okay, so this is something you have to understand, right? So basics of staging, this is an early rectal cancer. This is a polypoid mass. You can see the entirety of the black line of the muscularis propria is visible. And here is a tumor, and here is the muscularis propria. And again, histopathology. These are all our own pictures. And this is our own specimens and our own pictures. And you can see that it's a T1 tumor. There are a couple of lymph nodes. And here is a T2 tumor. And in the T2 tumor, the difference is that you see the black line. The black line is not seen anymore. Okay, so the tumor reaches the muscularis propria, but does not breach it. Okay, so this is T2. This is T2. Next is the T3, and here the as you can see, the black line has now been breached at several points. Okay, this is what we call the pushing border of the tumor, and nowadays we actually mention where the pushing border of the tumor is, because we want to give the surgeon an advance notice of where the surgeon cannot compromise to lose the mesorectum, because here is where you want the margin to be the widest, right? The pushing border of the tumor. Also, now we know that the depth of invasion, the pushing border, corresponds to survival and prognosis. We also know that the clearance from here to here, which I've drawn 16 millimeters, I think I've said here, from the pushing border is also important in terms of prognosis. So this is a T3 tumor, and here again is a T3 tumor, and here again is the T3 tumor, right? And then this is the T4A I was talking about. So these are all tumor breaches, but here anteriorly, can you see how the peritoneum has been puckered in? Can you see that? And corresponding to the histology, where you see the peritoneum is involved. So the peritoneum is involved in this little corner. And this is a T4A tumor because it involves the visceral peritoneum. Okay, sorry. So then I will do the MRI, and the MRI is a T2 sagittal, T1 axial, T2 axial, and a diffusion variant. Very simple, 5 sequences only. I hate places and centers where you go and you see that there are 14 sequences for a rectal cancer. You don't need it. Okay, you need only 5 sequences. You need a T1 broad axial, T2 broad axial of the whole pelvis, just to give you global staging, and then thin section, high resolution, axial and coronal images perpendicular to the long axis of the tumor, a T2 sagittal, and a diffusion variant imaging. Full stop. No need for GAD, no need for anything else, no need for fat saturation, stir, this, that. You only need to know what you are looking at. There is no need to do a lot of sequence. It only takes 20 minutes on the scanner. Okay. So here is a sagittal, okay, and here is, I'll try to hold this. So here is a sagittal, and as you can see, it's a long tumor, and this is how I would report this, okay. So here is a, I think, 9 centimeter tumor starting at the S1, S2 border in the upper third of the rectum and extends for 9 centimeters, reaching almost the anorectal junction. So this is the anorectal junction. reaching the anorectal junction. I would say that it is across the sacral hollow, opposite S2, 3, 4, and 5 vertebrae. I would say that it straddles the peritoneal reflection, because you can see the peritoneal reflection here, straddles the peritoneal reflection. I would say that the lower end of the tumor is so much above the puboanal sling and so much above the anal verge, because those two numbers you guys need to know whether it is an APR or not. So I would give you that number. And then on this sequence, I would look for the T4A that I talked to you about, whether there is any suspicion of peritoneal involvement. And the other important thing I would look for in this is the superior rectal artery and vein. So here is the superior rectal vessel. Can you see the superior rectal vessel? See that? These are the superior rectal vessels. Because you need to see the lymph nodes along the superior rectal vessels. And you need to see how high is that lymph node. Because both, of course, nowadays, all of you do anterior resection from the IMA. I know that. You take the IMA and you remove it from the root of the IMA. So gone are the days when people would have done localized rectal cancer surgery, right? So you even if you're doing laparoscopic or robotic, you would clamp the IMA at the root and take off the tumor. So the apical lymph node is removed. But it is not just that. It is also, if you're planning a neoadjuvant treatment, if the node is too high, beyond your scope of radiation, your standard radiation, then you need to consider something else, right? You need to consider if the node is really suspicious. Then you need to consider whether you need to give the patient total neoadjuvant or not, right? So those are important things. And then, of course, the next is the axial, and this is the axial. This is where most of the decision making is done. And as you can see, this is where the tumor has breached the rectal wall, muscularis propria. It is T3. Some of these fibers are very thin. Some of these breaches are very, very thin. So fibrosis can cause this, and I'll give you my opinion about fibrosis versus tumor. In fact, you can see it in this patient here. Sorry, I don't know how to fix it actually. One second. So the very thin lines are more likely to be fibrosis. The thicker lines are more likely to be tumor. But anyway, the other important thing is that if you see this tumor, see the hyperintensity. Tumor is T2 hyperintense, okay? There's a little bit of mucin secretion. Can you see that? Tiny little bit of white, it is the mucin secretion. Now, as you can see, mucin means tumor, right? So you've got tumor here, but the muscularis propria is clearly intact, it's black. You've got tumor here, right? But the muscularis propria is also intact, I think. Now, where you see these little lines, there is also something black. So this is possibly fibrosis. This is possibly desmoplastic reaction rather than tumor. So you need to be that careful when you're looking at it. Do I have tumor signal intensity abutting on my muscularis propria before I call something a breach, as opposed to fibrosis? Fibrosis will be across the entire circumference of the tumor, but the breach will be across where the pushing boundary of the rectum is. And this sort of knowledge is only there because I have examined countless pathological specimens myself. I have actually gone and looked at them when the pathologist has cut it, and I've looked at it, what is a tumor and what is fibrosis. And that is why I can tell you that this is tumor and this is fibrosis. So here you are. So then, and as you can see the CRM very well. Beautiful. Okay, there is no obvious mesorectal lymph nodes in here, but if there is there? I'm just trying to remember. Okay, nothing obvious. Okay. However, you can think about an EMV here. It's this here. You can think about whether potentially that is an EMV. It looks like a little broad loss of tumor, same signal as the tumor, loss of the usual flow void of a vessel. Look how vessels have got flow voids, right? Whereas this one does not have a flow void. So therefore, this could be a vascular invasion. I will, of course, look at diffusion and everything else. Okay. So there you are. Then, and of course, here also we look at pelvic sidewall, and here you can see a pelvic sidewall. Here you can also see a little bit of chemical shift artifact, and this is what we call a chemical shift. The chemical shift means forgot my tea. So chemical shift, I'll keep on talking. Chemical shift is related to presence of fat and normal nodal tissue, because if they're in the same voxel, then you see a little chemical shift. It becomes black on one side and it becomes white on the other side. Now, chemical shift relates to presence of fat, and it is an indicator usually of benignity. So if you see a lot of chemical shift in a lymph node, then it is likely to be benign. Likely doesn't mean that it is benign, it is likely to be benign. So you can see a little bit of chemical shift artifact on that particular lymph node, and that is possibly benign, possibly uninvolved. Now, of course, I will also look at the diffusion rate. So all of that would together form your report and your opinion. Okay. 1 second. And then, of course, you look at the coronal, and the coronal is to supplant what you see on axial. And again, you can now see a little bit of different perspective to the tumor. So it is actually a largely wall-confined tumor, apart from that little place that we showed to you. So this is like most likely a T3, N0, MX, EMV1, possibly, is what I would call it. Okay, right. Makonda, is that okay? The staging?
Yes. Just show us the normal structures in a standard pelvic MRI.
Okay.
Normal landmarks.
Okay. Okay. Okay, so this is a mid-sagittal MRI. So this is the bladder. This is the prostate. Symphysis pubis. Here is your here is the pubococcygeal line, which is very important. Yeah. Sacrum, coccyx. So this is the pubococcygeal line, right? This is the rectum. Rectum is divided into 3 parts: upper third, mid third, lower third. We will talk about 15 centimeters versus surgical finger versus what I consider to be the rectum. Defining the rectum is something that is very important. I'll talk to you about that. But that is it. Pelvic MRI is very easy, very predictable and very easy. Next on this axial.
Yeah.
So rectum. Okay. CRM.
The CRM is the pelvic fascial layers. The rectum you are showing.
CRM is the mesorectal fascia, sorry. Circumferential resection margin, or the same thing. We use that word interchangeably. CRM is what you guys call when you are operating, right? So anatomically, it is not the CRM. Anatomically, it is the mesorectal fascia.
The area you're showing rectum is all the layers there. You can see the lumen, and outside lumen, what is the black line just outer?
So the outer black line is a muscularis propria.
Yes. So beyond that, it is non-peritonealized. It ends there.
So the peritoneum is only there in the anterior third in the upper third. So peritoneum you can't see, Makonda. You will not see. This is the peritoneum. Can you see the peritoneum coming like this? In this case, there is a little bit of peritoneal seal.
Yeah.
So therefore, it has come up to the lower third of the rectum. And that is why the surgical textbooks or the anatomical textbooks defining rectum, the upper third of rectum, as a peritonealized margin and not, is rubbish, because that depends on the patient's peritoneal seal. And it is so variable. The degree of peritoneal prolapse in a patient is very variable, Makonda. You cannot use that as a criteria, because what that anatomical Gray's anatomy describes is what is there in a normal young individual. Then when you start getting pelvic prolapse in a female, everybody, then all of these things change, and therefore you cannot use any one criteria to say that this is upper third. So I divide upper third. So I will talk about that in a second. I've got a special slide for it. But you were asking for the, so this is again the base of the bladder and the prostate. And here is the seminal vesicle. You can see the seminal vesicle, right?
Yeah.
And these are the mesorectal vessels. These are the pelvic side wall vessels. And these are the levator plate, of course, sorry, the piriformis, pectineus, obturator internus, right? And these are the anterior muscle thereafter group outside the pubis. Okay, and this is the penile shaft. Can you see that? This is the penile shaft. Yep. And on the coronal plane, again, you know, obturator internus, levator plate, it's straightforward. You will see the rectum at the back, bladder at the front, prostate below the bladder. And in females, you will obviously see the uterus and the cervix and the vagina in between. Okay. So now, when it comes to the lower third of rectum, it is a little bit unusual because all of these theory and all of these nice things that I told you about the mesorectal fascia, it all disappears out of the window. You guys also know that how difficult it is to actually resect in the lower third of the rectum, particularly in a narrow pelvic male, because as opposed to a wider pelvic female, because actually there is no mesorectal fascia. It is the rectal wall that is the mesorectal fascia. They are together, right? So it becomes like this and it is together. And you can understand the difficulty here because here, any T3, even if it is for 1 or 2 millimeter, is going to become involved circumferential resection margin, right? And it doesn't take much. So therefore, if you are a clever radiologist and if you want to do good for the patient, if you are in any doubt about T1, T2, T3 in the lower third, okay, anteriorly particularly, overcall it because you want the patient to get long course radiation. I know the patient gets long course radiation anyway, but here you do not want to compromise because any breach here is involved margin. And if you look at your surgical literature about local recurrence rates, it is higher for lower third of tumor because of this problem, you know, because people do not give enough neoadjuvant treatment before operating and they leave tumor behind. Okay, so there were tiny breaches significant. Okay, and here I think is the only role of, there are two roles of the finger. Surgeons think that they have a brain at the tip of their finger and they can make all decisions on the basis of their finger. It is, to be honest, I put the finger too. But what I'm saying is that there are two roles of the finger. One is to assess that is this fixed or is this not fixed? Because this abutment, you will often see MRI reports saying that the prostate is involved. Prostate is almost never involved in rectal cancer because the prostatic capsule is hard and it is not easy for the rectal cancer to invade the prostate. It is not easy. It happens late. So you will often see this. Then a finger will tell you that actually the tumor is moving and therefore it is not fixed. Okay, so that is number one. And number two is this concept of, you know, free versus tethered versus fixed. There is a beautiful paper that shows the correlation between digital examination and MRI and how the two are discrepant. It doesn't mean tethered doesn't mean involved, but at least it gives an idea. And that is why before an MRI is sent to a radiologist, it is actually good for the surgeon to have examined the patient and actually give an opinion that I think the tumor is at this level and I think the tumor is fixed, tethered or free. Because that bit of information is important for me when I'm looking at here. Okay. The other thing is about the surgeon taking a call about what an anterior resection or low anterior resection, ultra low, or an APR is going to happen. That call is also based on the finger, right? Most surgeons will not do that on the basis of an MRI. Now, of course, I do believe that we can do it on MRI and we are very good at it. Babu, I'm on the top.
Oh, no.
Yeah. I just started, no? Another half an hour.
Is not coming.
Oh. Okay. Bye. Right. Maganda, I don't think that we are going to go beyond rectum today.
Yes, yes, no, we can continue, no problem. Rectum only today.
So, the peculiarities of the lower third, can MRI predict the type of AP resection? And this is something that we worked on and we think that it can. And I think you know that there are various types of AP resection in terms of the standard AP, which is, you remove keeping just the outer part of the external sphincter and you go, or rather along the outer border of the external sphincter. But there is also an AP resection, which is a more limited AP resection, which is called an intersphincteric AP. So depending upon the degree of anal canal involvement and the width of anal canal involvement, you can talk about what sort of AP resection a patient can have. So for example, here is a tumor extending into the anal canal, needs an AP resection, and I can tell you that the tumor replaces the muscle coat but does not extend into the intersphincteric plane. So this patient will get a standard AP. Here, on the other hand, the medial fibers of the external sphincter may be involved. So this patient gets either a standard AP or perhaps an extra levator AP, ELAP. Or when it comes to the fact that the tumor has extended like this, what is called the triangle of doom, and I'll explain triangle of doom a bit later if I can. Here you can see that the medial fibers of the levator plate are involved. Here, if the patient requires an AP resection, the patient clearly needs an extra levator AP, right? If you do a standard AP, then you're going to leave tumor behind. So I think MR rectum can actually predict what sort of AP resection a patient gets. So all this talk that we are giving is based out of a couple of studies. The first one was by Gina Brown, only on 20 cases. And what she did was all of them had only straight to surgery. They didn't have any radiation. This is 2001, the paper came out in Radiology, landmark paper. Only 20 patients, but they had the MR accuracy of T staging was 100%. 100%. None of us have ever been able to reproduce that, and we know why. Not because we are bad radiologists, just because she got few things wrong. But nevertheless, it proved the point that it is good. Subsequently came this landmark trial called Mercury. We were part of the Mercury trial, and that showed that actually it's very simple. Can MR predict a clear margin or an involved margin in a patient who was having straight to surgery or had previous radiation? And as you can see, MR was highly accurate, specificity was 92%, and it was more accurate than digital rectal examination. And this is really important. A fixed tumor on digital rectal examination corresponded to an involved margin in only 15% of cases. And that is what I mean by this concept that tethered versus. So once Mercury was out, practice changed across the continents and MR became the standard of care. Okay, so even if we could do a lot of things on CT, we started doing MRI. And this is the practice in the UK, and largely UK practice. It has changed slightly. As I said, this slide is old. This does not talk about total neoadjuvant. This does talk only about surgery, short course radiation, and long course radiation. The principle is very simple. The principle is that that earlier the stage, smaller the tumor, higher the tumor in the rectum, more you go straight to surgery. If you've got slightly more intermediate tumor, you go to short course. And as the tumor size increases, as it becomes more advanced, as the T stage worsens, as the CRM involvement increases, and as you go lower in the rectum, you give CRT. So as you can see, that for the lower third of rectum, even for an intermediate stage, you're giving CRT, okay? Whereas in the upper third of rectum, only in the advanced stage, you're giving CRT. Okay, so this is how it has changed. Now, in the local practice in India, for example, maybe some people will get CRT even here, lower third, early T2 cancer, may probably get CRT even here. And that is okay. I'm not trying to say that this has to be the practice, but you have to have a common practice at your MDT, and it is important that everybody knows what that practice is. Now, I'm not a radiotherapist, and I don't intend to give you a lecture on radiotherapy, but just because I'm part of the MDT, I know this bit. And the other thing is, as a surgeon, you must learn this bit of radiology so that you are making the appropriate decisions. I, as a radiologist, must learn a little bit about your surgery so that I can give you the right diagnosis. And this interdisciplinary working is really important, because otherwise you don't improve. You only improve because of interdisciplinary work. There is only one patient, right? So what the short and long of radiotherapy, basically, you have to understand that short course radiotherapy reduces the risk of loco-regional recurrence. It sterilizes the circumferential resection margin. Yes, but it can treat outside the mesorectum. So this is short course. The blue line is short course, the typical short course radiation field. And this is the long course radiation field, which includes the pelvic side wall. But short course does not downsize, because it is only high radiation over 5 days, right? So 25 grays over 5 days. Whereas long course is 60 grays over 6 weeks, correct, Mathanda? 6 weeks or 8 weeks? 6
Yes.
weeks. 60 grays over 6 weeks. Yes. So, so short course will let you think about considering enable sphincter sparing surgery. Will not. Long course will do, potentially. Short course will not downstage, although we disagree. I think short course does downstage, particularly if you do short course and leave the tumor for a bit longer, because radiation effect takes a bit longer to work. If you don't operate at 5 days, then it does downstage. We know that. And so before I should have put short and long course, I should have put this slide, is that, this was the standard. As a surgeon, you know this, right? This is the landmark Lancet paper, which was this was a meta-analysis of 22 randomized trials over 8,500 patients that showed that straight to surgery versus preoperative radiotherapy. Preoperative radiotherapy improved local recurrence and survival. Okay, and there were lots of trials, right? The Stockholm trial, the UK MRC, the New England trial, Japanese trials. So all these trials in the 80s proved that radiation is beneficial, right? And then came the Dutch TME trial, where short course radiation followed by TME surgery versus TME surgery directly, and that showed that and the MRC CR07 trial, and this was CR07 trial was a UK trial, and that showed that this is what they showed. Okay, that local recurrence was less with preoperative radiation, disease-free survival was more, and overall survival was slightly better with short course radiation. And the Dutch TME also showed the same thing. So basically, this paved the way for short course, and then subsequently the Swedish trial paved the way for long course radiation, right? Okay, so that is enough about literature. I'm not going to talk about literature anymore. I'm sure you guys know about this. So the next bit, I'm going to talk a little bit about the staging difficulties, and I talked already about fibrosis strands versus tumor strands. And, I reported that as tumor. It turned out as fibrosis. These things will happen. I will get it wrong sometimes. I will call this a T3. It will turn out to be T2. That is okay. That is okay. As long as I don't make a mistake of not predicting, this is the CRM, of not predicting an involved CRM. Now, here you see the CRM looks, so this is a coronal image, okay? And this is the anterior end, okay? So don't get confused. This is the bladder, right? This is the sacrum. So this is a coronal image. And here it looks like you could say that the peritoneum is involved, correct? Potentially, peritoneum is abated. But it is not, because can you see that pushing tumor boundary is inside that black line, right? The black line only goes here. And here is a breach, here is a breach, here is a breach. And then the black line is intact along all of this here, right? So therefore, this is not a peritoneal involvement. The tumor pushing boundary is along this aspect of the tumor. But this is to show you strands versus tumor breach, right? you can see that it is difficult. It is, you can, you will sometimes get it right, sometimes you will not get it right. And these are the classic fibrous strands, little thin ones, other side of the tumor pushing boundary. And these are the fibrous strands, okay? And you can see it's bland, it does not contain tumor or histology. The next little thing is about extramural invasion. And here, these are initial days before we learned about EMV. We call this tumor breach, okay, but it was actually a T2 tumor. And this is EMV. This is actually, you see the vessel beautifully on the histology? And here is a tumor inside the vessel. Okay, so that is why it is a extramural venous invasion. But on MR, initial days, now we know. We have learned this, but now we know. Okay. Should you do luminal distension? People talk about that, Italians do, the advantages of luminal distension. We don't. I think it is artificial. It compresses the mesorectum. It gets the numbers of what is the depth of invasion and all of those wrong. But some people do. Right. We already talked about vascular invasion versus T3. See, here it is a vascular invasion. See the vessel, tumor breaching. In this case, this was a T3. This is a V1, right? This is a tumor breaching on this side. See, both the sides are pushing. So again, sometimes a normal vessel can look like tumor, but here you can see a flow void. It is dark, so therefore it is not a tumor-containing vessel. Coming to nodes, of course, CT is bad here. MR is better, but still we lag behind. We are miles behind histology. Here we don't have histology. We have some dedicated contrast agents which are good for nodal characterization, but we don't use them routinely. So the thing you have got to understand is not just the size, it is the size, the shape, the signal heterogeneity, the contour of the node, the clustering of lymph nodes, perinodal tumor spread, and presence of necrosis. And to that, you need to add diffusion restriction. So all of these are important in characterizing a lymph node. Now here I come to this theory of ours, and unfortunately not published, but we know this for a fact. So your lymph node accuracy depends upon your pathologist. Okay, it does not depend upon you, because your surgeon of course. So if your surgeon is so good that the surgeon delivers 60 lymph nodes, your pathologist is so good that the pathologist dissects out 60 lymph nodes, right? Like my pathologist used to do. Then the possibility of finding tumor in very, very small nodes is very higher. You understand? So this patient, this is a 3.6 millimeter lymph node. Okay. This was the largest of 3 positive lymph nodes out of 56 harvested in this patient. So we call this N0 on MRI. This patient was bordering on to become N2, not only N1. This patient was bordering on to be N2 because there were 3 lymph nodes positive. Now, what I'm saying is, if your pathologist is harvesting 70 lymph nodes and you've got microscopic nodal breach, nodal involvement, and MRI will not pick them up. So when people say, when Gina Brown says that lymph node accuracy is 90%, I just tell her that your pathologist is bad. That's why you're so good. If your pathologist is very, very good, then you look bad because the pathologist will pick up nodes which you can't see. You understand? So what is Duke C in one center becomes a Duke's B in another center. So all this thing that we talk about, that we should give adjuvant radiation, chemotherapy, FOLFIRI, because this is Duke C and not Duke's B, is all rubbish. Because it all depends upon how good the pathologist has been. If the pathologist has harvested 60 lymph nodes, suddenly all your Duke's B that you did not give any chemotherapy would become Duke C. You understand my point? And
yes,
we proved that. We proved that. We proved that. The same surgeon moved from a center in Wales, Bridgend, to Birmingham, and suddenly his numbers of Duke's B to Duke C changed. Suddenly all his Duke's B were becoming Duke C, and they were all getting chemotherapy and the patients were living longer. So basically, it is the tenacity of the pathologist that is a very important factor in your nodal accuracy. Okay. So what my nodal accuracy was only 67%. that same MRI reader like me would have an 85-90% nodal accuracy in the hands of a pathologist who is only harvesting 12 nodes, as opposed to who is averaging 55 lymph nodes, you know. Pelvic side wall, again, important because you need to mention this. Roundness, loss of ovalness, tumor signal, gray, loss of tumor heterogeneity, heterogeneous signal intensity, presence of mucin, the node breaching the border, all of these are important characteristics. And of course, the other thing you've got to remember is sometimes a lymph node will cause CRM involvement, even if the tumor doesn't. Okay? And the presence of mucin. Presence of mucin is important. It's an important prognostic factor, important predictive factor. Right. So I'm just going to do a little quiz. So if anybody, any of the boys, girls wants to take this on, want to describe this to me?
You see, the black line is not.
Okay, so
Jyoti will answer.
okay, sure. Jyoti, go for it. Don't worry.
Actual view.
So it's actual view of
Right. Okay. No, I think Jyoti, you were trying to say that there was. You're trying to say that there is a breach, right?
Yeah.
Yeah. So this is the lumen, Jyoti, right? This is the lumen,
Yes.
right? And this is the tumor signal. Can you see the tumor signal? Hyperintense tumor signal. See the black line anteriorly.
Yeah.
So this is a protected muscularis propria. This is the peritoneum, bladder level, right? So peritoneum, beautiful CRM, right? You can see the CRM very well. So the tumor breach is between 3 o'clock and 9 o'clock around the posterior hemicircumference. Okay. And this is the width of the breach. Okay. That's a 7 millimeter. This is the pushing boundary of the tumor. This is the CRM or clearance, this much. Okay. And you can see that all of this is tumor breach. Now, which of this is tumor breach and which of this is vascular invasion is difficult. You cannot say that on one slide. So where it looks like a vessel is coming out and there is a little bit of white inside the vessel, this is probably vascular invasion. This is more likely to be actually the main tumor breach. So this is at T3B, right? N0 so far, what we can see here. Maybe there is lymph node at other levels. Right.
What are the other black shadows in the lateral wall? The previous slide.
Yeah.
What are these black
vessels?
These are all vessels.
Pelvic side wall, internal iliac vessels.
Okay.
It's a little bit of a seminal vesicle, Mahanda.
Yeah.
Okay. Little bit of vessel again, bladder, right? Rectum, CRM. This is sacrum, Walder, right? So, okay, I think this one is a good one. Okay, here you are. So this is the tumor, T2 hyperintense. You can see it on axial plane. You can see it is wall confined right here. So far it is wall confined. And can you see the node here on the CRM or just inside the CRM on the left side?
Yeah.
And then, yeah, great. Yeah. And can you see the vascular invasion? See the beautiful vascular invasion. See the two big vascular invasions on two sides. This is because it is going along the vessel. Okay. And here is a tumor, beautiful hyperintense tumor, EMV3. Okay. And so it is in the upper third going into the middle third of the rectum. Yeah, actually, yeah, just in the middle third. Lower third is paired, right? So I've got some selected pictures here. So the tumor intensity, okay, little bit some mucin. Here is the EMV, big EMV, right? Okay, I think that is good. Okay, Vakanda, I'm just going to move on a little bit to.
Yeah.
So this was only one of my talks. I had so many on rectum.
Yes, yes.
So this is MRI. MRI can be used in an MDT setting to assess the height of the rectal tumor. I didn't talk about this today. Staging with limitations. There are limitations. We've talked about triaging between surgery, short course and long course. I think MRI is superb at this. Presence of vascular invasion, prediction of complete response. We talk about response in a second. The type of low rectal surgery and pathological grading of the surgical specimen. MRI is highly accurate in predicting and involves CRM. However, there are several pitfalls with standard MR. It is important to know your own center's result. A volume sequence may obviate some of these issues. Okay. But superficial comparison between MR and the pathological specimen is problematic. So we did this. We know what the pitfalls are. I'm not going to talk about that today. So the next little bit, I'm going to talk about imaging post-neoadjuvant CRT in locally invasive rectal cancer, MRI, diffusion weighted imaging, MDCT, PET, or nothing. So this was a talk given at TMH Mumbai. So this is slightly old, guys. So please apologies if it does not reflect new data. I think my personal practice has changed since 2014 in India. Certainly it has. But some of the things I will show here you may not agree because this is good 6-7 years old. So apologies for that. But still, I think principles hold. Why should we bother to assess downstage? Do we need to assess downstaging at all? Okay, because all the original CRO7 and all the other trials basically said that if you give radiation and then if you operate, the patient is better off, right? So why do we at all need to assess downstage? That is partly because of this concept that surgical resection may not be necessary in complete responders. And that was this Annals of Surgery legendary paper by Haber Gama from Brazil that talked about operative versus observing non-operative treatment in complete responders in rectal cancer, right? I'm sure that you guys know this long-term 7-year results. And this initially we were skeptical, but then all of our UK centers started reproducing this data. And now it has become common practice that in certain group of patients, we are observing. The radiation oncologists are thrilled, the surgeons are not so happy, of course, because they're not getting to operate on their favorite organ. But this is real life. So this is why it is necessary to talk about complete responders. And the second thing is we should not resect if there is distant disease progression, right? Because then we should give chemotherapy instead. Can we suggest a less mutilating sphincter saving surgery? Can we, if we have downstaged it to the point that we have got it less, can we do a less mutilating sphincter saving surgery? Can we predict the type of surgery? Can we modify the APR? Can we do an intersphincteric AP or can we consider an ELAP? Do we need to do the AP supine or prone? Important decision, right? Do we need to do a prone AP with removing the coccyx? And we need to prognosticate after the radiation, before the surgery, because the depth of invasion and all of this is important. And lastly, of course, we love to image. We love we all love to image. So just for the fun of the thing, we would like to know, right? So all of these are the reasons why we would do the downstaging. Now, the regression grading was done by Dvorak et al. On a histological basis, which MRI sort of stole. We sort of nicked it from the histology literature. And as you know, the TRG gradings are 1, 2, 3, 4, 5, whereby 1 is the best, where there is complete response, no tumor, and 5 is the worst, where there is absence of any regressive changes. And the pathologist can actually say this very well, that what is the degree of response, okay, if you do a biopsy on the specimen. And we know that actually the Kaplan-Meier curves are different if the patient is a complete responder versus a patient who is not a complete responder. And we also know that the depth of invasion after neoadjuvant chemoradiation is important because it is a predictor of outcome. We also know that involvement of the circumferential resection margin in rectal cancer is also important in prognostication. And we also know that prognostic subdivision of T3 into T3A, B, C, and D is also important. Can MRI pick up this true depth of invasion? This is the question that I want to answer. But routine postoperative MRI is bad. Okay, and here is us again presenting our data on CT and MRI following long course chemoradiotherapy for locally advanced rectal carcinoma. So this is, you know what, Makanda, I must have 10 abstracts on rectal cancer, and hardly any of this is written. You know, it makes you so feel bad that you have done all this work, you have presented internationally in places, but we have not written these up, unfortunately. So it is very sad. So this is for 3 years, 57 patients that went long course. 15 were not resected, so 42 patients entered into study for 28 low, 13 mid, and 1 upper. Okay, so we demonstrated downstaging on CT/MR in 22 out of 42. Clear CRM was correctly predicted in 38 out of 42. But you look at this overall T accuracy, how bad is it? 48%. Under stage 6, over stage 16. Nodal accuracy was also not good. And 5 cases of complete pathological response, and none were correctly predicted. And this is our own MRI. Mind you, it is very old. So 2007, right? We were not that experienced. Today it will be better. But what am I trying to tell you here is that MRI, just a normal MRI after CRT, is not good. It is like tossing a coin. Okay. So the only thing it is good at is predicting an uninvolved CRM. Okay, so we are not good. And there were 4 cases that progressed on long course. Okay, and they were all diagnosed on CT, right? Because they had lung metastasis. So you ask yourself a question that why bother doing the MRI at all? Here is an example, right? Here is the tumor, complete response. You cannot see the tumor at all. Here is the tumor, node, cannot see the tumor, cannot see the node, right? This is complete response. You can see the tumor, right? You see the black line has been reconstituted. This is near complete response. You can see the node has become smaller. It has become darker. Great response. Pelvic side wall, it wasn't there before. It has appeared now. So this is likely to be a reactive change rather than a truly involved lymph node. Unlikely to be progression, unlikely, because radiation would have involved this bit involved, right? Or maybe I'm wrong. So there was a node here on this side as well, which is not seen. So maybe it is a different plane. Maybe it is a slightly different plane. But anyway, what I'm trying to say to you is that here is a tumor involved CRM, large mass extending into involve the CRM, extending outside the CRM, right? And you can now see that it has significantly shrunk, right? Now, where is MRI bad? MRI is good at saying the CRM is involved, okay? MRI is good at saying that there has been some degree of downstaging, maybe grade 3, grade 2 downstaging, there has been. But MRI will still say that this is still an involved CRM. Now, if this is all fibrosis and not viable tumor, there is no way I can tell that whether this is a T3D or a T2 or a T whatever. I can't. Now, today with diffusion weighted imaging, this is before the age of diffusion weighted imaging. Today with diffusion weighted imaging, we are much better, much better. We are of the order of 70%, but don't think that we are of the order of 90%. As we are in the in a pre-neoadjuvant setting. Okay. And the other big important problem is this. You know, here is a high signal mucin. Clearly, as you can see, it is breached, right? So mucin breached the wall. I will call this a T3 disease. But this mucin, as you see histologically, is bland mucin, right? Does not contain any tumor. Fatty mucin. Okay. Not fatty degeneration, sorry, not. So basically, this is bland, this does not contain tumor, but I don't have histological eyes. I can't tell there are 5 cells which are containing cancer or not. So these are the pitfalls, and this is why people that would claim that they have 90% accuracy in restaging MRI after CRT are talking out of their anal canal. They're not talking out of their mouth because it is impossible to actually be accurate because of these limitations. You have to be honest to yourself, right? So my question was that will CT do? That is what we thought. Why do we need an MRI? Because CT will also show the downstaging. CT will also show the lung metastases, right? So CT should do. And so we this is those days, this is old. So we said that post radiotherapy MRI has poor therapeutic impact, as local progression rarely occurs. Local progression, if any, can be assessed by a dedicated CT. Restaging CT is required as distant metastases may develop, and more refined techniques for MRI are desirable. This is in 2006. And of course, they have appeared now. So I think we are better. So this does not hold. So I'm going to finish with one case. Is that...
Yes.
that okay?
We have talked more than 1 hour. Yes, last.
Okay, so 53-year-old male, no comorbidity, intermittent rectal bleeding for 4 months, weight loss of half a stone. Tethered low rectal tumor, posterior wall, 4 centimeter from the anal verge, 1 centimeter above dentate line. This is my surgeon telling me, right? That much. Okay, that much. My surgeon will give me this information. Okay. Invasive adenocarcinoma on biopsy, rest of the bowel clear on colonoscopy. Just look at the total amount of information I have. Okay. Okay, so CT shows no distant metastases, and here is a T3 posterior hemiannular tumor in the middle third of the, opposite of the lower sacrum, in the middle of the rectum, opposite S5 to C1, 15 millimeter top of sphincters, about 15 millimeter from the dentate line. So surgeon said 10 millimeter, it is 15 millimeter. This is the pre-CT MRI. I don't know, the movie will not work. Sorry, Mahanna.
No, take it.
But it's okay. This is the tumor posterior hemicircumference, quite right. Here is a vascular invasion. This is actually a vascular invasion, I think, reaching into looking like a lymph node. And here is the other pitfall, that sometimes what we call a satellite nodule versus a lymph node on histology. And there is, there are some pointers towards that. I think we're not going to talk about that today. I think the case, these movies are not working. No, sorry. So likely 2 involved nodes in SRA. What did I say? We talked about vascular invasion. So you've seen that. So what is the treatment options? Mahanda, very quickly.
Yeah, we will go for pre-op chemoradiation.
Long course plus 8-week delay.
Here practice is mostly long course.
Yeah. So this patient same long course. Okay, with synchronous FU, with synchronous 5-FU folinic acid, etc. I think nowadays some people do capecitabine, right? This is old time. So 5-FU folinic acid. Now, I think the potentiating chemotherapy is capecitabine. So anyway, so this one, and then the patient does surgery, right? Repeat MRI after, and as you can see that there has been some degree. So this is before, and this is after. This is some degree of downgrading. Unfortunately, this will not work, but you can see that this was before, and this is now after. There is significant reduction in the EMV and the size of the tumor. Again, this will not work. So all of this looks good. The patient gets an ELAP because of the triangle of doom, and I wanted to explain that to you. So just very quickly, let me explain that. So when you get tumor in this little corner here, so when you are doing a CRM, when you're doing a mesorectal excision, there is a high propensity of leaving tumor behind in this little triangle. And this is called the triangle of doom. And if you have a tumor here, then our surgeons would like to do an extra levator anterior section. And this patient gets an ELAP. Here, see, Makunda? Yes. Because of this tumor, you will get an ELAP. Okay. Yeah. So, and then this is the resection. These are the axial sections. These are the axial sections. And here is the tumor. You can see the tumor is marked with a round circle. Here is T3, beyond the muscle, 4.7 from the CRM. again tumor, and here is the histology exactly corresponding to this little breach here. You can see the breach here, right? 2.1 millimeter. And here is the okay, so here is the lymph node. Here is the lymph node on MRI. Okay. Here is the lymph node on histology.
Very accurate.
Oh yes, it is.
Yeah.
It is. And here is the tumor margin here. This is vascular invasion. See the vessel bursting into the tumor. So here is the summary of the specimen. Moderate differentiation, YPT3, 4 nodes positive, lymph node harvest 33. So YPT3N2. You can see the MRI specimen, and here is the tumor. See the tumor is marked, and see the tumor here. It is very, very accurate. And then, of course, diffusion weighted imaging has improved things, and double contrast touch. We won't talk about this today.
Okay, Dr. Chowdhury, you have talked about 70 minutes. Fine.
Yeah, I know. I think.
Yeah.
I think we should stop now. That's good. We've already
We'll have
talked
more
about
classes.
it.
If you
Yes.
give us time, we'll have little more classes. It's all
I
your
think that
time.
was rectal cancer only. Yes.
Yeah. Okay.
Thank you very
Thank
much.
you very much. Thank you.
We have run out
At
of
least
time.
residents will be able to identify the rectal area. They can identify the mesorectum. They can
Yes.
look at the lymph nodes. So these are the basic
Yes.
things they require.
Sure. Can you do me a favor?
Yeah.
Akanda, can you just, because we have to do our appraisals of teaching as well. So if you get a little feedback, then if you could just send me a little feedback just on an email.
Sure. It will be in our YouTube link also. The class will be uploaded in YouTube link also.
Okay.
So we'll have a lot of views afterwards also.
Okay, but that's okay. But if you could just send me an email with just a feedback so that we can.
Okay. I'll send you.
For our
Sure.
UK job, we are
Okay.
also tested,
Yes.
Yes.
Sure.
So that will be very good. Thank you for asking. Thank you for asking me to talk, and it's been a real privilege.
You are you're in Kolkata now or in States?
Yes, in Kolkata.
Okay. Thank you, Dr. Chowdhury.
Thank you very much. Thank you.
Thank you. One of my ex-PGT is waiting there.
চল হয়ে গেছে কি করবে